On to our next dynamic duo. So I'm going to present both Dr. Stephanie Feldman, who is Assistant Professor of Medicine in the Division of Cardiology here at Weill Cornell Medicine and the Director of the Cardio-Oncology Program, as well as Dr. Joseph Scandura, who is an Associate Professor of Medicine here at Weill Cornell as well, and Scientific Director for the MPN Center. They will both talk to you about cardiovascular or cardiac health with a shift in focus on pulmonary hypertension, which was actually a topic of interest also in the patient committee, and so we'll start with Dr. Feldman first, actually.
Hi, thank you so much. Thank you so much for the kind introduction, and thank you for having me. Oh, sure. I can talk without slides, but I'm a visual learner, so I assume you guys would all like one too. Thank you. I was here last year, and I will do a little bit of a review from last year, but I have to say this is one of my favorite conferences to be at, so thank you for having me. I think it's it's really awesome to be with patients. I like talking to doctors too, but the patients are really what I do this for. So let's see. I'm going to be mindful of the time so I can give Dr. Scandura his time as well. And here goes. So my disclosures, just actually somebody I met through this conference last year, which was a fun experience, but not really directly relevant to the talk today. So my objectives for you as adult learners are that you can recognize and review from last year, but I'll also review again for those of you who weren't here in case you don't remember, the connection between MPNs and cardiovascular disease. We'll describe strategies to optimize cardiovascular health in patients with MPN. And then I want you to understand the basics about pulmonary hypertension. It is a complicated condition that I don't expect you to know everything about, but I hope to give you some of the basics. So first, and most importantly, there is a connection between cancer and cardiovascular disease. This is multifactorial, and it's the reason why my field exists. So I am a cardiologist, but I run the cardio-oncology program here. And so we know that there's a connection between cardiovascular disease and cancer, and it's multifactorial, and we're still learning more every day about that. Some of those are common cardiovascular and cancer risk factors. We think about the big seven, and those are things like obesity, high blood pressure, hypertension, diabetes, smoking. But the other things that factor into that are some of the factors, genetics in the cancer itself, also cancer treatments. So I move on then to focus on what we're talking about here today, and to emphasize, and not to scare you, but I think to bring importance to the topic, is that patients with MPN are at increased risk for cardiovascular disease. This is a nice illustration from one of my colleagues I actually went to medical school with, who's very interested in MPNs and cardiovascular disease as well, or Livia. But looking at the mechanisms, less important, but what are we worried about for patients with MPNs? We're worried about blood clots, as you just talked about. We're worried about blood clots as a cardiologist, means myocardial infarction or heart attacks. We worry about heart attacks that can lead to, or other things that can lead to, heart failure, so the heart pump not working or being too stiff. And then the topic that we'll focus on today is pulmonary hypertension. So if you've ever been in clinic with me, and I see some of my patients, so I'm excited to see you here. For HIPAA, I won't say who you are, but this is something that was coined in the context of prostate cancer, but I think it's applicable basically to all cardiovascular disease, but really for caring for patients who have cancer. And so I use the ABCDEs, and we'll go through those again. Sorry for those of you who were here last year. It's a repeat, but repetition, space-based learning is also good for adult learners. So we'll go through E. The first I would say is the A is awareness. Just knowing that you have cancer and are at increased risk for cardiovascular disease is important. The other A is to remind me as a cardiologist to think about aspirin. Many of you are on aspirin, and it's guided by your hematologist, oncologist. But for me as a cardiologist, if you are not on it, to think, would you benefit from being on the aspirin? I'll next move on to the B's. So blood pressure. So blood pressure, I think, is one of the most important things that very easily gets overlooked. So blood pressure. When we think about blood pressure, it's checked every time you go into the doctor's office. I usually tell patients when you're going into the doctor's office, it's especially to see your hematologist, oncologist, you're thinking about treatment changes. We worry that your blood pressure may be higher because you're stressed or you're nervous. And so this is why I usually advocate for making sure you're checking your blood pressures at home as well. Happy to talk about best practices and strategies for that. And we don't want to neglect blood pressure because it does play such an important role in your cardiovascular health as well as your cancer treatment. So the goal for your blood pressure, so the new ACC-AHA, the big cardiology committees, we really want to try to keep everybody's blood pressure less than 130 over 80. That would be the magic number. Ideally, there are some recent trials, maybe to keep it less than 120 over 80, but I would say, I think a basic practice would be 130 over 80. And if you're seeing numbers over that, to make sure you talk to your doctor about it, and is there something that we need to do? The one thing that I'll bring up is there seems to be, when we look at the mechanisms for some of our MPNs, cardiovascular disease, it looks like perhaps there's a role for the pathway that involves the renin-angiotensin pathway. One of the drugs that we have to stop that is ACE inhibitors. And so there is some data that patients, say with Polycythemia Vera, who are treated with ACE inhibitors, actually have improved hematocrit, and they also have reduced need for the cytoreductive drugs. So this has not made the guidelines, and every patient with PV does not need to be on an ACE inhibitor. But for me, this means that if you have high blood pressure, hypertension, and you have PV or an MPN, perhaps there's some benefit, and we should use ACE inhibitors over the many other blood pressure drug choices we have. The C is for cholesterol and cigarettes. And I have to tell you, in 2025, I forget about the cigarettes until somebody walks into the room and you can smell them. So it's very important to think about cigarettes. And every doctor's visit is an opportunity to talk about tobacco cessation. Your hematologist or cardiologist are happy to do anything we can to get you to stop smoking. If it were easy to stop smoking, then nobody would smoke. But we hope that you will strongly consider it. Sometimes a cancer diagnosis can increase your likelihood of quitting. So we want to make sure we take that opportunity. And then the other part that I spend a lot of my time thinking about is cholesterol. Your cholesterol as somebody with an MPN should be checked once a year, which tends to be a little bit more than the guidelines for the average population. Why? Because there's increased risk for cardiovascular disease. And we know that if your cholesterol is higher and we control your cholesterol, we can decrease the risk for cardiovascular disease. And as I imagine you already talked about this morning, and I'm sorry I missed your talk, but there is some evidence for the role for statins for patients with MPNs, talking about the inflammation, not just the cholesterol. So I've had many patients in my clinic, some of you here after the conference last year, and we talk about who should be on statins. Should we put them on for everybody? And so the easy answer would be to say, yes, sure, we could put statins on everybody, but statins are prescription medications. There's potential side effects with the muscle aches that you may already be experiencing as a patient with an MPN. And there's the potential risks for muscle breakdown, rhabdomyolysis, interaction with other medications, and liver injury. And so I try to be thoughtful. I joke as a cardiologist, I would love all of my patients on statins. But really the patients who I put on statins would be, we take a look at your lipids. We take a look at the new fancy lipoprotein A that we're supposed to be checking for everybody once in their life. And we look at your 10-year ASCVD risk. What's your risk for cardiovascular disease? If you would benefit from a statin, I'm happy to put you on one, happy to figure out the right dose for you. And then the other thing is, if you are getting imaging for any reason, many patients tend to have cross-sectional imaging, a CT scan. This was not done to look at your heart and your heart arteries. We actually get a free look at your coronaries, and this is what I call the cheap version of a coronary calcium score. And so this lets me know, is there plaque buildup on the outside of your arteries? And if so, we know from large data that this would increase your risk of having a heart attack. These are the patients who would definitely benefit from having an LDL, bad cholesterol goal of less than 70, and most people can't do that with diet alone, and so we'd add on a statin medication. I'm happy to talk more about that, but I will move on. So the D is for diet and diabetes. So you say, what diet should I follow? What's best for my health? It kind of depends on what your health conditions are. If you have high blood pressure, we think about a low salt diet. If you wanted to look up or write down, the best evidence is for the DASH, D-A-S-H, diet. If you said, I really want to lower my cholesterol, but I really don't want to be on a statin, I would say Mediterranean diet. And so what's Mediterranean diet? Picture yourself on the Greek islands. You have olive oil, you have avocado, you have fruits, vegetables, nuts, legumes. You really want to minimize your red meat and saturated fats. That's the Mediterranean diet. That's going to help lower your LDL, your bad cholesterol. One of my fellows was just teaching me about the portfolio diet. That's another one to look up. Everybody's looking for the next diet, but portfolio diet is actually very similar to the Mediterranean diet. It just has a focus more on plant-based and decreasing meat. I would say, try to have your protein from chicken, fish, less of the red meat. And then the other D is for diabetes. And so in addition to checking your cholesterol once a year, we should be checking and screening for diabetes once a year because, again, cholesterol, diabetes are risk factors for developing coronary artery disease, plaque buildup in the heart arteries that we know you're at increased risk for. And last, but I would say most certainly not least, is exercise. So all of us, your doctors, your nurses, you and your family, should all really be working towards getting 150 minutes of exercise per week. This is the guidelines from the American College of Cardiology. This is guidelines from many different organizations, including those for patients getting treated with cancer, so ASCO as well. So 150 minutes of moderate intensity exercise. This doesn't mean you have to go to a gym. This doesn't mean that you have to be on the bicycle, the treadmill. Walking is fine. Everybody's now thinking about steps. I would say if during treatment you're not feeling well, you rest. And it's really important to make sure you're listening to your body. But when you're feeling well, and I would think about it as part of your treatment plan, it includes exercise. This we talk about, in particular with patients who are undergoing stem cell transplant, because that can be a very deconditioning process. But I'd say staying in shape is very important for you. So 150 is a lofty goal if you're doing 0. So I say start with a goal of 5 minutes twice a week. If you have a very busy schedule, you want to try to get in your exercise snacks, 5 to 10, 15 minutes, whatever you can do. The mental barrier of not being able to work out for an hour doesn't need to exist, but make sure you're moving your body. And then the other thing for all of us as we get older and we're on different treatments that can affect our bones and our muscles is to make sure that you're doing 2 days of light weights. Don't start doing CrossFit or any of the crazy exercises, but you want to think about light weights, 2 to 5 pounds, doing something that's weight-bearing activity. I also say things like squats, lunges, all of those are going to help with your bone health and your muscle health. So that's my plug for exercise. We don't prescribe it like with a prescription pad, but I think we probably should. And next, this is also a review from last year. So we talked about Cardiology 101. So if you've sat in my office, you know that I break up the heart into these 3 parts because I think it makes it easier for me to understand, to make sure I don't miss something, but also for patients to understand. The heart's pretty complicated. It's basically 3 things. The heart's your plumbing system. That's your heart arteries. Most people are worried about having a heart attack. That's your plumbing. The heart is a pump. The heart pumps blood to your lungs to get oxygen, and then once it gets oxygen, out to the rest of your body. That's the function of the pump. And then your heart has electricity. That's the squiggles you see on the EKG. This is what we think about when somebody has an arrhythmia. That's electricity. So for today, we're going to talk about the pump. As a reminder, and I like videos, what are the issues with the heart pump is, so the heart's a pump. If the heart is not pumping well, meaning it's stiff, or the pump function is reduced, that can cause congestive heart failure, which is a pretty scary term. All it means is we build up fluid in our legs and our lungs, and it can cause symptoms of shortness of breath, sometimes hospitalizations. The pump I also think about as the valves. You can have valve issues, not usually related to treatment or to any of the particular risk factors, but we can be born with or develop over time leaky heart valves, valvular regurgitation, or stiff heart valves, stenotic valves. That can cause pump failure. And then lastly, we'll talk about pulmonary hypertension. So you guys have graduated this year. It's Cardiology 201. We're going to talk about pulmonary hypertension. So my questions I hope to be able to answer for you in the next few minutes. What is pulmonary hypertension? What are the symptoms? How do we diagnose it? and then what causes it. And then we'll focus, and I'll turn the mic over to Dr. Skandor to talk a little bit more in the context of our patients with MPNs. So from the Pulmonary Hypertension Association, I like this graphic here. So what is pulmonary hypertension and what are the symptoms? Pulmonary hypertension just means increased pressure going from the heart to the lungs. That's the pulmonary artery. We don't usually think about that side of the heart because we think about the left side where blood pumps out, goes to the brain and the rest of the body. But there is the other side of the heart, and we can have increased pressure on that side. That's just what pulmonary hypertension is. The symptoms, pretty nonspecific. Mainly we can have fatigue and shortness of breath, which you'll know can also be symptoms if you have anemia, can also be symptoms attributed to your MPN. When we have later stages of pulmonary hypertension, you can have severe breathlessness, chest pain. Sometimes people have dizziness or fainting. The medical term for that would be syncope. And then we can develop symptoms of heart failure, particularly right-sided heart failure, leg swelling, shortness of breath, waking up at night, short of breath, and getting extra fluid in the belly, ascites. So how do we diagnose pulmonary hypertension? My echo images didn't come through. I think these are my old slides, but that's okay. I like pictures, so I'm sorry. As a cardiologist, I should show you an echocardiogram. If you've been in my office, we've looked at your echocardiogram. But the way we diagnose, if we're suspecting pulmonary hypertension, is to do an echocardiogram. Echocardiogram is the jelly on the chest, and we take about 100 pictures to look at the heart from all different angles. With echocardiogram, things that we're looking for pulmonary hypertension would be the right side of the heart, which can be sometimes difficult to image, but the right side of the heart looking bigger because of this higher pressure over time. We also look to see if the valve on the right side of the heart, the tricuspid valve, is leaky. And if we use that tricuspid regurgitation to calculate and to estimate what your pulmonary pressures are, the pressures going from the heart to the lungs. If we are concerned that there is pulmonary hypertension based on symptoms, an echocardiogram would be a basic screening test. Then we may think about doing more testing, blood work, other imaging tests, and the gold standard really is to do a right heart catheterization. Right heart catheterization, you go into the heart catheterization lab, we give you medications to keep you comfortable, and we put a catheter into the venous system, either through the neck, the arm, or through the groin, which is what this picture illustrates here. This lets us put a catheter inside the heart, which helps us measure what the filling pressures are. A diagnosis of pulmonary hypertension has changed over time, but the invasive assessment would be a mean pulmonary arterial pressure of more than 20 millimeters mercury. And so that's what we're looking for there. So there are 5 major categories for pulmonary hypertension. I expect you to know none of these things, but just to know that there's 5. And the most common causes of pulmonary hypertension are the group 2 and the group 3, which are left-sided heart disease, meaning coronary artery disease, heart failure, all heart problems. So this is where the cardiologists think about pulmonary hypertension for the most part. The other more common is lung disease. That's the group 3. That's for people who have perhaps a smoking history, COPD, sleep apnea, chronic conditions where you can have low oxygen levels that can also lead to increased pressure going from the heart to the lungs. I highlight here group 2, group 4, and group 5 because those are the 3 types of pulmonary hypertension that are predominantly associated with patients with MPNs. So group 2, the left-sided heart disease, we've talked about and we understand. Coronary disease, heart failure, those can increase the risk of pressure building up inside the heart and then high pressures going from the heart to the lungs. Group 4 is a group related to blood clots. We know in the patients with MPNs, we worry about blood clots. And so that's one of the potential causes and things to look for if we find that you have pulmonary hypertension. And then lastly is group 5, which I would say is a little bit of a bucket list, but is pulmonary hypertension due to some other medical condition, and one of which is hematologic disorders. And that's thought to be one of the more common reasons why patients with MPN develop pulmonary hypertension. So lastly, I wanted to talk about the treatments for pulmonary hypertension, because I don't like to tell you that you're at risk for something and then not give you what we're going to do about it. So first, you're going to do all of your ABCDEs to prevent left-sided heart failure and cardiovascular disease. Otherwise, we're thinking about treatment for pulmonary hypertension focused at treating the underlying cause. So we have to figure out which group pulmonary hypertension you have so we can target therapy for you. If we find that you have pulmonary hypertension, we've done some of the testing. Usually you want to have at least a cardiologist, if not an advanced cardiologist, advanced heart failure transplant pulmonary hypertension specialist, because some of the therapies you're going to need or you may be considered for should be with those degree of specialty. I say it's above my pay grade, so I refer you to my friends, but I know what to recognize and look out for. So when we talk about targeted therapies, it depends on what information we get from the right heart catheterization, what type of pulmonary hypertension you have. But from a patient perspective, that could mean pills, inhalers, injections, infusions, but there are all different types of treatments for pulmonary hypertension. And then the last part I put here just to consider is that surgery is an option for patients. Only if you have the blood clot type of pulmonary hypertension, that's the group 4. Sometimes we need to think about surgery, but otherwise pulmonary hypertension in my mind is not typically a surgically managed disease. Unfortunately, we don't have my last slide, which has a nice photo of me and my nurse practitioners to say thank you. But and contact information for our clinic. But thank you guys very much for having me. I want to thank you so much for sharing your patience with me. And to my boss who supports this, my nurse practitioners and nurses who really help take care of all of you. So thank you.